Getting started. Everyone hear me okay? Good. Awesome. All right. Hi, everyone. Before we get started, just a few housekeeping items. If you didn't already hear Shannon, she will be muting everyone, but we are going to be doing some practice updates later, so you will be able to unmute yourselves when that time comes. And please also feel free to use the chat box for questions and conversations throughout the duration of our time today. This webinar will be recorded. So hi again, and thank you for being with us today. This is going to be our third webinar in the Telehealth Initiative series. So next slide, please. So today's discussion will be focused on workflow design, and while some of this may be a little bit of a refresh from our time together at the virtual event a few weeks ago, we do have some good new resources to go over. We'll be reviewing a case study and walking through that, and also it's just a really good time, I think, as we hear about hopefully positive things about starting to think about how we reopen as a country and kind of get back to normal. It's a good time to start thinking about what the implementation of telehealth will look like in your normal practice environment, since it's been a little bit of a different case with everything going on with COVID. So then we'll plan to leave a majority of the time to do some practice round robin type updates and hear from you to just ensure that we are creating the right resources, we're delivering the right content and support, and also identifying any gaps that we should look to address through the initiative. Again, especially since we've had a little bit of a different progression here, given the expeditious way we've all helped to implement telehealth, given all going on. Next slide. Neither the planners or the speakers have any disclosures to report, and this webinar is available for one PRA Category 1 CME credit for those attending the live session. And the next slide gives some objectives for our participants today. So following this webinar, you'll be able to describe the ways that practices, the workflow can be adapted to facilitate the use of telehealth as a part of daily operations, and develop and finalize a plan to implement telehealth in practice. Next slide, please. So again, just a refresh of the content today. We'll do a brief overview of the goals to accomplish during the workflow design portion of your practice prep, and introduce some new resources and approaches. And then we'll also review a case study from one practice and their use of telehealth. Additionally, we will be touching on how to help ensure patients know about your telehealth offerings in the practice. I think we've, talked a little bit about this in the past, but some of our colleagues have been taking next steps in terms of their profiles on different sites and platforms to just make sure that the telehealth offerings are searchable by their patients. Next slide. So just a quick refresh of some goals to accomplish during this step. The checklist on the right of the screen has that real detailed list of consideration and goals to accomplish during this phase of the process. And again, while the majority of you participating are already using telehealth, it may not look exactly the same now as it would if you or when you fully integrate that into your normal practice while you're seeing both in-person patients and doing virtual visits. So a few highlights to pull out that my colleagues will also dive a bit deeper into. So getting key input from the care team and the patients to help set the schedule. So how will this impact the care team and their normal flow of work? Are there busier times of the day that this may get confusing if you intermix different types of visits and things like that? And then are there certain times of the day that patients would likely be more susceptible to use telehealth visits or access to these types of visits and want that available to them? And then document current and future workflows. This makes it easy to call out spots where something may need to change or be handled differently than you would an in-person visit. It also helps identify what training elements might need to happen across the team. You'll likely need to start developing some protocols for when a telehealth visit is appropriate to help ensure you're setting expectations with patients, and you're also setting your schedulers up for success as well. Again, something a little bit different than probably the environment that we're working in now, where most things are being addressed via telehealth if possible. So this may look a little bit different when we're getting back to the normal way of practice. Planning for how to schedule, document, and bill for those telehealth visits, and then also, of course, setting up the appropriate space in the clinic to conduct visits. So what equipment might you need? Dual monitors, being able to kind of visually do that visit with the patient while documenting which exam room will you use, how's the lighting and sound, and other considerations like that. So I'm going to hand it over to my colleague Yvonne now to dive into more detail on a lot of those concepts, as well as introduce some additional resources.
Thank you, Stacy. Go ahead and advance to the next slide, please. All right, so we're going to cover designing the workflow. I'm sorry, go back one. There we go. And these are some of the areas that we're going to cover in the topic, the whole topic of workflow. And mind you that a lot of this follows pretty closely with the telehealth initiative playbook. So it'll be familiar if you're using that playbook to help. So we're going to talk about scheduling, checking in and arriving patients, virtual rooming tasks, provider visits, post visits, and billing for the visits. So we're going to break those down into a little more detail. Next slide. All right, so for scheduling, you want to think about how that looks on your technology. Obviously, if you're doing telemedicine, you're using technology. You may be using a teleplatform that integrates with your practice management system and your EHR. Hopefully you are, and if you're fortunate enough to be doing that. If not, you want to be considering ways that you make all of those systems work together. So you want to designate a visit type, a televisit. It can just TELE, however you want to designate that on your practice management system. If you want to further delineate for the type of visit, you can add virtual care, telephone audio only, if you want to separate them out like that. Excuse me, I have dogs running around. So then you also want to think about building your visit template. How is that going to look throughout the day? Are you going to have telemedicine visits interspersed between in-person visits? Are you going to designate specific times for telemedicine visits, or is it going to be more random? Do you want to designate a certain time of the day, a block of time, an hour or 2 hour time period where it's just telemedicine visits? Or is that going to be occurring after hours or on weekends? Is that where it needs to fit into your schedule? So then the other thing you want to think about are your visit fields. So there may be some information that might be necessary for anybody who's going into your practice management system, looking at the daily schedule, that might be helpful to them. Some information might be like whether you have a telemedicine consent on file, if that's something that still needs to be gotten. You might want to have some technology related information in there, like their phone number, email address, whether they have audio only capability, something of that nature, if they've had trouble connecting in the past, or if there's something like the patient is hard hearing, a potential issue that could potentially impact the telemedicine visit. So you might want to have some fields or some notation places for things like that. And then you also want to think about how you're going to reschedule visits when that need comes up. Where you be changing, if there's a potential to change from in-person to telemedicine visits or vice versa, how is that going to be handled? If patients cancel completely without rescheduling, how is that going to be managed? How is that going to be, who's going to take care of rescheduling that patient, just making sure people don't fall through the cracks. Next slide, please. All right, so checking in and arriving patients. So the things you need to think about in terms of this is, one, who's going to do it? And we're going to be talking about roles and responsibilities a little bit later in the presentation. But just some things about who's going to be responsible for check-in, how is that going to look? And a lot of that's going to be dictated by your technology. So you're going to identify which staff will be responsible for patient check-in. Is that going to be staff initiated, patient initiated? Who takes the payment? How is payment taken? Is it something that's done electronically before the visit? That type of thing. And then with arrival, how will staff know or the provider know that the patient is ready and online for the visit? How will that notification take place? Who's going to be notifying who? And will there be any rooming tasks to complete? And which staff will be involved in that? Will a clinical staff member initiate the visit perhaps, and maybe deal with some preliminary visit stuff before the physician starts the provider starts the visit? Do they need to cover medication reconciliation or something of that nature, reason for visit? Do they need to cover those things and document those things? And then if that's the case, if you have a sort of a clinical person doing some pre-visit stuff like that before the provider comes on, how do you then notify the provider that the patient is ready to begin the visit? And will the provider have real-time access to the information that clinical staff just entered into the system about the conversation they just had with the patient? Next slide, please. So then you've got your patient arrived, checked in, any type of rooming tasks were already done, and then you start the provider visit. Prior to the visit, the provider is going to want to have had a little bit of a time to review the patient record. And I wrote review vital signs there, and I say that tongue in cheek because that could actually be something that you're looking at depending on whether your patient has some remote patient monitoring capabilities. Or if your clinical staff did some type of pre-work on the visit and they've collected maybe historical blood pressure readings that the patient reports or glucose readings, something of that nature. You want to make sure that you've got all that information ready for your visit. And then you're opening your encounter to start your visit. You conduct the visit with your patient and then document that visit. You want to include the level of service to make sure that you build the appropriate E&M code and have the documentation to back up that E&M code. You want to go over treatment plans with your patient. Make sure that you're completing any e-prescription or other orders as well. You want to include in your documentation a statement of how that visit was conducted, audio visual, via telemedicine platform, audio only, telephone, that type of thing. And then if other staff are going to be involved in concluding the visit, you want to work out how that handoff will be done. And if the provider is going to close the visit, make sure that the patient is aware of next steps if you don't have a staff member taking over to clarify that for the patient. Next slide, please. All right, so post-visit, now this is assuming that these are things that are necessary for general post-visit regardless, but the difference is the provider going to be doing it? Is there a staff member that's going to be doing it? Is it going to be your clinical staff or some other business office staff? It just depends on how your system is set up and how your practice is set up. But some of those things that might need to take place are patient education about medications, about treatment plans. Maybe they're getting ready for a procedure, so they need some education on how to get ready for that procedure, or instructions on where to go for testing of some sort if that's been ordered. You want to be able to go over scheduling, going ahead and scheduling the next visit if possible. Who does that? Is that, again, going to be the clinical staff providing the patient education, or are you going to hand that off to a front desk person to complete? Again, it just depends on really the way your technology works, the size of your practice, the complement of staff you have. And then, of course, you want to make sure that you've completed all the documentation that the patient has been given, any educational materials electronically or otherwise, completion of any orders, and completion of the visit scheduling. Next slide, please. Now, In preparing your care team, you want to make sure that you've included them in all of the planning and preparation, that you've trained them appropriately, and that everybody is clear on their roles and responsibilities. And we're going to discuss these in a little more detail. Next slide, please. So including your staff in the planning and preparation is very important for one huge reason. If they're involved in the development or the modification of your workflow, you'll tend to elicit more buy-in and ownership of the process. Not to mention your staff has in-depth knowledge and experience with your current workflow. They will be the experts in how the new or modified workflow will affect them, their process, and the patients. So it's also a good idea to include your IT and or telemedicine vendor to assist with some of this planning. How is that technology going to integrate with existing technology? Do they have tips on different parts of the system that would be helpful to utilize, or a way to utilize it that's more efficient? You want your staff to be involved in kind of defining what their roles and responsibilities are. Again, they're the experts in what they do, and they will have more buy-in if they feel like they've had a part in deciding what they do. They also have probably some really good ideas on how to handle those pre and post visit tasks, patient education, and those other pieces. And your staff also will be good for helping with arrangement of the space that you use for telemedicine. Next slide, please. So then when you talk about training the care team, your first step is going to be with your technology, obviously. You can't have a telemedicine visit or any type of workflow without knowing how to utilize the technology. And again, you want to incorporate your IT folks and or telemedicine vendor in that training. It's helpful to identify a champion in each department or area that can be kind of the go-to person for your clinical staff, or your go-to person for your front desk staff, or whomever, if they're having issues with the technology. You want to be able to teach them how to do some troubleshooting with the software, with the equipment, whether you're using laptops or tablets, things of that nature, because they're going to be not only dealing with issues themselves, but they're probably going to have to be helping patients deal with some of those technological issues as well. You want to develop and train in some scripting. How are you going to educate your patients about telemedicine? What kind of things are you going to say to them? How do you want that presented? You want some scripting on for your front desk staff or whomever is doing the scheduling, making sure that they have all the components necessary for the visit, that nothing is forgotten in the process of scheduling. And whether that's new and established patients, there might be different scripting for that. Certainly with new patients, you're going to be getting more information in terms of demographics, insurance, and things of that nature. And then you also want scripting for rescheduling the visits. It's always ideal to have a patient reschedule right when they're canceling, rather than cancel completely without having a visit rescheduled. So you want to develop some scripting and train your staff on that, so that hopefully they can close that gap. And then, of course, training on the workflows. Of course, that's a lot easier if your folks have been involved in the development of those workflows. But again, you want to make sure everybody's roles and responsibilities are crystal clear. We don't want to have an issue with, well, I thought so-and-so was responsible for that, or I thought so-and-so was going to do that. You want everybody to know what they're doing so that it goes smoothly, and your patients have a good experience and you have a good experience. And then, of course, policies and procedures are a piece and a part of that. As Stacey alluded to earlier, having that documented information is helpful to refer back to. It's helpful for training. And you might even want to develop an algorithm that you can see visually. That might help staff kind of solidify that process for them a little bit more. Next slide, please. So roles and responsibilities. Now, these are just some examples of the different processes your various staff might be part of. There is no one size fits all for this. It really will depend, again, on your technology, your specialty, the size of your practice, the complement of your staff. Obviously, if you have a solo physician with 2 or 3 employees, there's going to be a lot more responsibility for each person compared to a larger practice that has several different departments. So again, these are just some ideas. Could your front desk deal with the scheduling? They might be educating your patients on the telemedicine process and assisting them with the technology. Your clinical staff might be doing that. They might also be involved in, like we talked about earlier, rooming your patients, initiating that visit, providing post information. Maybe they do some scheduling for the patient post-visit. And then there's your business office. They have a role to play in this too, as far as coding and billing and making sure all of that process is going well. They might even be involved in some patient education in terms of insurance verification and letting patients know what exactly their insurance covers with regard to telemedicine. Next slide. And then you're going to be partnering with your patient. You want to include patients in planning if at all possible. Some practices have patient panels that they kind of advisory panels that they develop, and that would be a good resource for assistance with planning and implementation of a telemedicine program. Or you could just do some type of informal survey. Patient involvement will help you identify the level of interest and understanding that your patient population has about telemedicine. What type of scheduling would be most helpful to them, most convenient for them? What would they take advantage of? What would not be helpful? How do they want to receive that information? Are they using, do you have a patient portal that's very active? Do they want that information written in a pamphlet or some type of sheet? Do they want that education done in person? Especially people that are not comfortable with technology, they may want that communication done in person. You want to develop a variety of education tools because, again, people learn in different ways and their brains think in different ways, absorb information in different ways. So you want to develop a variety of tools to assist your patients in learning about and using telemedicine, including the technology assistance, education about what types of visits are available and appropriate for telemedicine, what conditions are appropriate, when it's time to do an in-person visit versus a televisit, that type of thing. And then you want to elicit feedback from your patients. Is what you're doing working? Is it helpful for them? Do they feel connected to the provider? Do they still feel like they have that relationship? Just some general feedback so that you can evaluate and reevaluate and then make some changes if necessary. Now, Bisant is going to take over, and she's going to start with some of those billing and administrative tasks.
Can you guys hear me?
Yes.
Thank you, Vaughn, Shannon, and Stacy. Good afternoon, everyone. As you continue your implementation process, one of the key areas you should spend some time on is the billing and administrative tasks that you need to learn as you're tackling the telehealth space. I wanted to emphasize, because we are in an emergency period, many waivers have been put in place to facilitate access to healthcare services. Things may look very different a couple of months from now. This period, however, has given us all a unique opportunity to examine all of the area that may affect the practice. So we want to keep monitoring and learning what the state and the federal government and the health plans will do with many of these waivers. In any case, we will continue to advocate on your behalf regarding any of these issues. My hope for the future is the policymakers in all sectors will learn to appreciate how telehealth can benefit patients first and foremost. We know, for example, Medicare has the originating site issue. For the commercial plans, we have the reimbursement and coverage matters, things related to teleprescribing, the established versus new patient, telephone consultations, location of the patient during the visit, practicing across state lines, other legal considerations such as liability and malpractice insurance coverage. We are seeing billing and reimbursement guidelines changing every single day, and this goes to show you how essential training for your coding and billing staff is. I was a biller for over 15 years, and I've never seen anything changing in this pattern here locally or nationally. So we're also still learning specific billing guidelines and RVUs for the different type of these visits, like the virtual check-ins and the e-visits, the telephone services, the remote patient monitoring. And then we want to learn how to start integrating these different CPT codes in the appropriate modifiers in the EHR, or if you're billing directly from the platform. Due to the complexity of billing during this time, I highly recommend to create your own billing cheat sheet and keep updating it as you continue to change, things continue to change. We have a couple of examples available here for you. You'll see the Texas and our chart and the Florida chart. Also, I know ACP and AFP had some guidelines as well. Please feel free to use any of them and modify as things change. Also, you will need to keep in mind considerations for self-pay patients. In addition, ensure you can capture and record any necessary patient signatures, consents, practice privacy notices, or any patient forms through your patient portal, while you're keeping in mind patients who are not or don't have capability to access the portal. The more you prepare ahead of time, the easier it will be for your staff and for other physicians in your organization to ensure the cycle of payments and billing will run smoothly. Find a doctor. Next slide, Chen. If you decided to continue offering telemedicine post-COVID, hopefully, it is important to think how you're existing on your patients would know this service is offered. Simple marketing techniques can be used to launch any new service line, and we'll touch upon these during the next webinar. Example of these would be updating your provider information, either by adding the information in CAQH or health plan directories. For instance, when we talked to Blue Cross Blue Shield here in Massachusetts about the project, they advised us for all our practices to add telemedicine offering in the provider directories. Also updating your websites, your patient portal, your frontline staff, they can promote that while the patient is in the office. You can do direct phone messages, email marketing, social media campaigns. We will provide more details on this topic and a variety of marketing scripts that you can use. Next slide. So after carefully examining and designing the flow that works for your practice, you should officially launch the program with some initially scheduled patients visits. Be prepared to support patients with any scheduling or technical issues during the visit. Be prepared to support other physicians and care team members with technical issues during these visits. Ensure your patient intake flow is working as intended in your workflow design. When possible, try to gather post-visit feedback from your staff and patients. Adjust procedures as necessary. It is a learning process and we will continue to evolve. Ensure you are tracking key success metrics such as improved outcomes, strained patient-physician communication, increased compliance, gaining more market share. Evaluate how documentation and billing procedures are working, adjust as necessary. Start with one payer and test. Although telehealth appointments should ultimately be better utilized for appointment times, in the early phases, ensure you have extra time built in for telehealth visits. This leaves time for troubleshoot technology glitches and get you comfortable with this new way of interacting with patients. Try not to take shortcuts because you are working with a smaller scope. Design the initial implementation of telehealth as if you are launching it in full scale across your practice, including full updating of your flow and ensuring quality care by initiating a quality assurance program. One thing I want to mention, if you have multiple sites, telehealth, as we know, can be used for a variety of conditions and patient population. Try to prevent creating siloed programs that require similar yet separate resources. Instead, standardize telehealth across all your practices, keeping in mind that each location may have its unique challenges. Consider developing training templates that can be customized depending on the needs of these multiple sites. Finally, when you're successfully up and running during the initial implementation, celebrate the successes and recognize ways to understand better and communicate with your patients about their conditions and care remotely. Most important is demonstrate success to justify scaling the programs. For the telehealth workflow, can we go back one more? Yeah, thank you. I wanted to remind all of us with the telehealth implementation playbook, there are many helpful toolkits at the appendixes at the end and workflow designs that you can use. Next one. For the case study, I probably won't go in details because Yvonne went over many of the steps, and we will be emailing you this case study, and I want to allow more time for you guys all to speak. So you can review the case study and you can create templates that fits your practice setting. However, I do want to recognize Dr. Kristen Meisinger from Cambridge Health Alliance. It's a great organization here in Massachusetts with great commitment to diverse and underserved population. Dr. Meisinger shared this flow with us, and she created it in a very, very short time, I think in about a week, to help launch all the primary telehealth in all her primary care clinics. There are many good nuggets. If you can go through the slides just to kind of show. There are some good nuggets in the flow designs. There's some easy templates. There are some role descriptions. There are some duties, triage plans, easy scripts to co-create, especially if you have multiple sites and you are trying to standardize the process. With that, I think I will kick it back to Shannon for the round robin discussion. Thank you. And if we have any questions as well.
Thank you, Bisan and Yvonne. Excellent information. I know one thing that I definitely made note of was the idea of the patient advisory panel, because that's a great way to test your messaging and test your service. So that was really good advice. We wanted to give a few minutes to hear from you. We know that as we began this journey with this telehealth initiative, it was prior to the COVID-19 pandemic, and we didn't realize just how fast and furiously telemedicine and telehealth would be implemented in practices. So we want to make sure that we're meeting your needs and that we're adjusting as appropriate. So we wanted to hear a little bit more about how you are doing. I did not identify any specific physicians from the Texas cohort, but each one of the states will have time for a physician from their group to speak. But I'd like to just ask now if any physicians from the Texas group would be willing to speak for a moment about your experience, if you're currently using it, in what ways, whether you're at home, what are some of the challenges that you're facing, what are the common conditions that you're using for telehealth visits, maybe a word about your vendor. I know that there was the Office of Civil Rights waiver that allows you to use a non-HIPAA compliant vendor. Did you choose that to start with? And then at what point do you plan to transition to one that is HIPAA compliant, knowing that this will be a service that you will use ongoing? And then maybe how you're letting your patients know about the telehealth offerings. So unmute yourself and speak up if one of my Texas cohorts has something they'd like to say.
Hi, this is Al Smith in the Rio Grande Valley of South Texas. We've been using the telehealth via Skype, iPhone, FaceTime, and also with Duo. Our ECW has a mechanism for us to use it, but we chose to try this other first. Once it becomes HIPAA, we need HIPAA compliance, we'll probably go back to ECW. We have not had any real trouble other than sometimes the connectivity is a little difficult. In our office, we do have fiber optics, so we have really, really good broadband here. But I think the problem is that we're in a rural area, and I think that it's the mechanism for connection in the rural homes and stuff, but that gives us some difficulty at times. And sometimes we'll log in and we can see them and hear them, and then suddenly we start losing them, and then we have to switch over to the telephone and do it. But we usually have a chance to when we do that, we usually have a pretty good chance to see what they look like, get an impression of how they're doing, And we try to, if we have to look at a sore or an ulcer or look at their feet for edema, we try to do that quickly in the very beginning, so that if we lose connection, have to go to a phone, then we have already done some visual that we needed. But I think all in all, our patients are very receptive to it. They like it. Some of them have said they would like us to continue this afterwards. We've been planning to do this for some time, and probably 12, 15 years ago, I was part of a grant to do telemedicine linked to a local school. And we were able to listen to sound bites of the heart, look at the ear tympanic membranes and the throat. And the school really liked it. We liked it very much. But at that time, you don't get paid for it. We had a conference with some Texas legislators that were part of this, watched how we used it, and they said, man, this works great. We're going to fast forward, we're going to rocket this forward so that everybody can use telemedicine and you can get paid for it. And that was 15 years ago. So it hasn't been a rocket forward, but it is there now. And I'm really happy to see that. So I've had my say.
Thank you, Dr. Smith. That was excellent feedback on your experience. I appreciate that, and I'm glad to hear that things are going well. If you could just say maybe one thing about challenges that you would like to see us help you address, is there anything that you would like to see us focus on?
I think probably trying to understand the various platforms that can be used. I know that ECW has a platform, but we've also got an ambulance service that is going to be moving to telehealth, and they've got I think it's called the ETF, where they through telemedicine, there are many in a rural area. There are many people that use the ambulance service as a taxi to the hospital when they really don't need it. And with the new programs, they will be able to pick them up, and if they decide that they don't need to go to the emergency room, they can bring them to our office during the day, during hours, and they can also bill for that. Whereas now they cannot bring anybody to their office. And so, but after hours, that's going to be more difficult because we are rural. We don't have a hospital in our county. We're trying to work out with one or two of the hospitals setting up an urgent care here, but that's been very slow. But there is a telemedicine component to that, where they could then, the ambulance service can then contact any one of the practices through telemedicine after hours and make a decision whether they can wait till the next morning, or maybe it can be taken over that way. And so it's going to have to be a platform that they can use also. And obviously they're not going to be using ECW. So it'd be very helpful to know the various platforms that are available that also are affordable in a rural area.
Mm-hmm. Yeah, that's a good point. And to be able to transition easily from, ambulance service to you or to urgent care. Okay, good information. Bisan, I'd like to pass to you now to introduce somebody from the Massachusetts group.
Dr. Shaw or anyone from the Compass group would like to speak? I think a couple of them are on, luckily, with us today. Just waiting for them to unmute.
Yeah, this is Dr. Shaw. Can you hear me?
Yes.
Yeah, I think my colleague, Dr. Kozlow, might be here also. So feel free to chime in, Dr. Kozlow. But I just want to thank every one of you guys for putting an effort into putting these webinars and sharing your stories. I think one of the key highlight I would like to share is we are seeing the societal adjustment patients and providers are going through, because as a provider and patients are used to having the healing touch inside the exam room, now trying to provide that care via virtual platform, no matter how easy we have made it, whether it is through platforms which are easily deployable, I think the patients are struggling the most. We are seeing some challenges around not having the appropriate equipment or internet at home. But at the same time, many of the patients are just glad to do audio visit with their provider. Previously, they were expecting a call from a provider only when they reached out as part of the on-call. Now the ability to have a scheduled visit, even if it's an audio only, because they don't have the ability to do the video component, they are appreciative. So we are working on how to improve a provider and a patient experience through video visit. The simplest way to put it is the audio gives you the ears, the video gives you the eyes. We are still in search of giving the ability to our clinicians to provide a healing touch. And I think that's the promise of connected health, where we are looking into things such as remote patient monitoring, ability to deploy medical grade devices to patients' home where they are 4G enabled. We are not doing this right now, but we are looking into it, where we deploy 4G enabled devices to patients' home. And the moment they step on the weight scale or they take the blood pressure, it directly goes to the cloud. So we are not in a position to ask patient, do you have a smartphone? Do you have a tablet? Do you have an internet? Removing those boundaries is very important. But unfortunately today, we are trying to optimize the audio and video to the best of our ability. I don't know if Andy, you want to share some of the other experience we are seeing.
Sure. Thank you, Drew. If I may. I think he hit a key term there, is removing boundaries. And when we have, talked to our patients, informally at this point about their telemedicine experience, they're really talking about enjoying the lack of what they perceive as formality, in the sense that they're only receiving the provider's attention when they make the trip to the office. And we've begun to break down those barriers at our practice through chronic care management and other efforts. But this is really helping patients. In a sense, I can see why they'd feel disconnected by not being in the same room, but also in a sense, they're feeling more connected, because I think they're feeling a little bit more, taken seriously, for lack of a better term, through these non-face-to-face methods. Whereas, if you're contacting a provider on call, it's usually a brief thing, it's not billable, so the provider has a disincentive to spend a ton of time with you. This is kind of blurring those lines, and I think this will really help when we get back to whatever is the normal in terms of managing risk and all that, because again, we're giving the patient a sensation that they're able to be touched and really cared for when they're not physically present on site.
Dr. Lopez, your mic is on.
Okay.
Thank you, Dr. Roslow.
Well, I'm sure as all of us were thrown into jumping into this technology, where we were, we have Epic, which was using another software called InTouch, which was not working, and now they're working with Zoom, but that's not up and running right now. They're doing some testing with some of the sites. So a lot of us went to either Doxy.me or Doximity. I think some felt that they were HIPAA compliant versus Zoom. But we were allowed the providers to use whichever software they were comfortable with. I think the patients do enjoy it and would like to continue it. I think they like the flexibility of picking a time that works best for them. The way we've tried to use our support staff is, one, to make sure that they have the technology ahead of time, because a lot of our patients don't have either smartphones or computers. So we still have to do some of the visits via telephone. With Zoom, they're working with Epic, and if the patient doesn't have MyChart, that's a complication there as well. So we're looking at helping patients have access to MyChart and get more registered. So most of us are using Doxy.me and Doximity, and pretty happy with it. I think some of the patients who have poor Wi-Fi connectivity, you know, you start with the video and then end up with a telephone call because it keeps going in and out. That has been definitely an issue. But I think for the foremost, that patients do like connecting with their providers. I had my patient earlier today. I'm in the office, seeing patients in the office and video, but she walked me around her apartment and showed me all her pictures. And so there's a lot more connection, I feel, going on. And regarding challenges, I think working out the initial flow of who was going to help set up the call, who is going to figure out when follow-ups are going to be, where they're going to be televisit or telephone. I think a lot of that we sort of are still working on and has improved since we started. Right now, most of my patients, I just tell them I'm going to send you a text before just in case I'm running behind or a little earlier. So I sort of give them a 30-minute range for me to contact them. And if not, I send them a text saying I'm going to be a few minutes late. And that has been working very well. Regarding billing, I can't tell you how many emails we get regarding which insurance is doing what. I would really love sort of a simplified grid to say, this is what you do with this insurance and this insurance. Most people have been helping out, but the information just keeps, you know, being updated. You know, first they said everybody was going to cover whether it was a telephone call or a video call, the same rate. And now we're seeing that some insurances are doing that and others are not. So it has been a little challenging regarding that aspect.
Thank you, Dr. Lopez. Matt, would you like to invite the Florida groups?
Yes, I'm going to have Dr. McDyer speak for a moment. Dr. McDyer, are you still on? I was chatting with him. Maybe I'll do Dr. Howard first then. You want to say a couple comments?
Sure. It's been a good experience. Great thing about this, what's going on, is the workflow that you guys talked about, and really engaging staff and what they can do while you're seeing these patients, and before and or after. I've had very good luck with using Doxy.me, but when it doesn't work, I usually switch over to a phone call if necessary, and that's been fine. Most patients have been very appreciative. I always do a survey in real time and talk to them about the benefits. In fact, in my virtual waiting room, I have an entire section on telehealth and what it's about and what the benefits are, as well as support and things like that. And it's been paid pretty much at the same rate. Some commercial payers are still having some issues, but we're working them through, obviously state specific. It's something that needs to be done. It's a great platform for patients for a lot of things, but not all things. And I do have patients come in when a physical exam is necessary. And, you know, it's been a little more common recently with some of the strange things that people have had, but overall, the platform itself works great. This initiative is very helpful in terms of not just looking at platforms, but looking at specifically the workflow and other things that are helpful during and after patient care. So it's been very good. Some of the challenges are mostly technology driven. You know, some of the patients in my area are 80, 90 years old, and you know, they can't use the technology for one reason or another, but most can. And luckily I have online ordering for everything, so that hasn't been a problem. Just getting patients tested for different things also hasn't been an issue, but it's a great platform. Some of the new patients, because I spend, you know, I'll spend an hour on telehealth with them sometimes, and which is a long time. And we discuss, you know, many aspects of their care. I usually go into how they feel and stuff. So it really gives you a good way to examine all areas depending on the patient and the problem. But overall very successful.
I have a quick question because I hear this a lot among the group, as well as just anecdotally and other things that we've participated in or physicians that we've talked to. When there is kind of an interruption of the video visit and you transition to a phone call, what does that look like from a billing perspective?
Are you asking me or
I think I heard
staff,
it
or what?
but
What are we
Dr.
doing?
Howard, I'll take your approach first if you would like to share.
Sure, sure. So basically, everything is timed.
Yep.
So when I chart, I put start time, end time. If I have to transition to FaceTime at the present time, that of course still is something you could document. If I have to go to phone only, then I'll document that. It depends on how much we actually got done. Sometimes I do video and then phone audio, so I still have both. So it just depends, but I would say for most of the time, I'm able to do the video portion. But if it is phone, then I bill just the phone.
Okay. So if it were, say you, from a time perspective, spent 20 minutes doing the video visit, and then you had to, something dropped the call and you had to use an audio only, would you bill both of those codes or just one or the other?
No, I would just bill the actual visit code with the 95 modifier.
Perfect. Thanks. Helpful.
Thank you.
Thank you.
I saw Dr. Libby's comment in the chat about, whether or not it's helpful seeing the home environment of the patient. And listening to some of you, it sounds like that has been incredibly helpful as far as your connection with the patient to be in their personal space. Would anybody like to comment about that specifically, or about going over their medication regimen with the patient in that manner?
Oh, I would. I actually, it's Corey. I have the patients grab their pill bottles and I look at their pills because sometimes I can't remember if they're scored or not. And so I actually have them show me that, or pull out prescription, pull out their actual bottles, or very often when I do blood pressure monitoring, which I do quite often, I have them do a blood pressure while I'm on the phone with them. So it's actually very helpful for them to sometimes be home so that we can see what exactly they're taking, because sometimes they are not really even sure. So it's been helpful.
Thank you. Anybody else?
I would imagine that being able to see the patient using some of that monitoring equipment would also be helpful to make sure, like you're talking about taking a blood pressure, Dr. Howard, making sure that they're putting it on the right way and using it appropriately.
Yeah, good point.
Absolutely.
Well, we're almost at the end of our time. Stacy, did you want to go over the next steps?
Sure can. So this was really helpful for us today. We really wanted to do a check-in with all of you just to see, where you were at and what might we need to adjust from even a timeline perspective, and some of that has already happened, but just making sure that we're continuing to kind of deliver the resources and support that you need on an ongoing basis. So, we'll be taking some of these learnings today, as well as if there's anyone that, has any follow-up ideas, needs, questions, feel free to reach out to any of us. As you may remember, part of this initiative was to kind of do a pre and post assessment of the experience implementing telehealth, realizing that some of those initial questions have had to change since most of you are already using it. We've been working to tweak those, and we are still planning to disseminate that survey. I'm hopeful sometime mid-May, and we'll leave it open for about 4 to 6 weeks to complete as well. And then Our next webinar is scheduled for Thursday, May 28th. It will focus on partnering with the patients, but we may also kind of spend some time just checking in again as well during that time too. And I believe also we are going to plan to switch up the time to test if that is more a better time for folks. So I think we're going to do a 6:30 Eastern time, 5:30 Central time for that one. So after kind of normal work hours. Next slide. I think we're done. This is just the link to CME, and Shannon, I'll let you say any additional words on that.
Thanks, Stacy. So as Stacy mentioned, we are going to test a different time with the next webinar into the evening, and hopefully that will help with some of your schedules. I did want to let all of you know that we will be sharing the slides from today with you. And Bisan did mention that there would be another set of slides that we can share that will include the case study and the contact information for Dr. Meisinger in case y'all need to contact her. We do thank you for joining us today. Please note that the CME evaluation form is linked here, so we'll have that in the slides for you. Also, as we did with the virtual boot camp that we did on April 4th, we are placing those on the telehealth initiative section of the practice transformation webpage. So if you've not had a chance to sign on or access that, let myself or Stacy or whoever's leading your state cohort, let us know so we can help facilitate that for you to make sure that you have access if you're wanting to review any of this later. But again, we'll be emailing the slides for you for today. So with that, if nobody has anything else, we will conclude today's program and let you continue with your day. And thank you for the time that you spent. We hope this information was helpful, and we will be in touch. Take care, everybody.
Thank you. Bye-bye.
Bye.
Thank you.